I'm really delighted for presenting this session. So we'll be discussing about the basics of pacemakers. And if we have some time, we can go over through some pacemaker ECGs. So we know that permanent cardiac pacing has really come along a long way over the years. In 1958 was the first pacemaker that was implanted, but it was a variable external pacemaker. And a true implantable pacemaker was in 1960. Then a lot of sophistication and automatization took place. A lot of features got incorporated into the pacemakers, and rate responsive pacemakers and other sophisticated stuff came in. Then pacemakers initially were considered a contraindication for getting an MRI scan. And in 2011, we had the MRI safe pacemakers. And now it's a miniature device, which is a transcatheter pacemaker, which is a leadless pacemaker. And you don't need a lead for it. It's only a small device that gets implanted through via transcatheter approach. So the basic pacemaker would be a device which is implanted below the collarbone, going through the transvenous subclavian vein access or the axillary vein. It is a device which has a lead connected to it, and the lead gets connected to the myocardial tissue. So it's stimulating the heart from the endocardium. The pacemaker generator has a circuit. The scan is called the implantable pulse generator. It has a circuit, which is a computer circuit, which contains ROM and RAM memory. There's a battery. Usually it's a lithium iodine battery. And it has a connector head on which the lead gets connected to it. The lead goes to the transvenous route and goes to the heart. And there are different insulations covering this lead, and the tip is localized to the heart. This is the skeleton of the pacemaker. So it shows a connector block in which the leads get attached. You have the battery, and you have the integrated circuits. As far as the lead is concerned, there's one connection to the pacemaker device. So that's a connector. Then you have the lead body covered with an insulation material, usually polyurethane or silicone. And then there is a electrode at the tip, which has the sort of mechanism in which it gets fixed to the endocardium. Here it is a screw which we have to retract it from the proximal portion of the lead, and it kind of screws into the endocardium. This is an example of a bipolar lead, and I'm going to go what is the difference between a unipolar and a bipolar lead. So this is one way of fixing the lead by a screw. This is called the active fixation lead. So as seen in the top figure, you have a screw which is already there. You just rotate the whole lead and it gets fixed into the endocardium. And below we have a lead in which the screw gets retracted when we open it up by moving the lead proximal part. This is the passive fixation leads in which it does this is not a screw-in mechanism. The lead gets lodged into the trabeculum of the heart, and these are those kind of tines or feathers which are silicone made, and they lodge into the trabeculum of the heart and hold the lead in its place. So this is called a passive fixation lead. Generally, a pacemaker X-ray will show you the device, and you can appreciate in half of the device, you can see that radiolucent shadow, which is the battery, and the other part has the circuit. So it's a circuitry of the device. And then it's a single chamber lead, which is going through the subclavian vein and going to the right ventricle apex. In this case, it's a bipolar lead, and it also has a screw. This would be the radiological appearance of a tined lead, in which you have these two, those two black portions represent the pole. So it's a bipolar lead, and it does not have a screw at the tip. So it is a tined lead. Contrast this with this lead, in which it's a dual chamber pacemaker with bipolar leads, and you can see the helix extending out. So that's the screw which is fixed into the endocardium. So that was a standard pacemaker. Then we have the biventricular pacemaker, also called the cardiac resynchronization therapy pacemaker. The whole logic behind putting this these pacemakers are that these are put in patients who have heart failure, EF less than 35%, who have a left bundle branch block pattern, and who have refractory symptoms despite optimal medical therapy. What happens with left bundle branch block on the left of the figure, that when the patient has a left bundle branch block, so the impulse goes down the right bundle, activates the right ventricle of the heart, and then by cell to cell conduction, it goes to the left ventricle. So the basal lateral portion of the left ventricle is the portion which is the least, or you can say the most lately activated portion of the heart in a patient who has left bundle branch block. So if you manage to put a lead onto the lateral wall or the basal lateral wall of the LV, and we do that by going through the coronary sinus, you can activate that portion of the heart. And when you put a lead into the right ventricle and you put the lead through the coronary sinus into the basal lateral portion of the left ventricle, you can achieve biventricular pacing and hence negate the effects of left bundle branch block and resynchronize the heart. So that's the way a biventricular pacemaker works. So we do a venography of the coronary sinus, locate the branches. Usually we go for a lateral vein, posterior lateral should be the ideal vein. And then we go, it's like a small angioplasty that we do and deliver the lead into the target vein. So a CRT pacemaker X-ray will look like a device which will resemble a pacemaker device, a slightly bigger device. But then there are three leads coming out of the device or connected to the device. And you can see one lead into the right atrium as marked, one lead into the right ventricle apex. And then there is one lead going through the coronary sinus into one of the branches. This is an AP view, so it's a more of an overlap. But if you do a lateral view, you can see nicely that there is a separation between the LV lead and the RV lead. This is a device which is a bit different to what we've seen so far. So this is a bigger device. It's a more bulky device, and it has a top part which looks more rectangular. So this is an ICD. So this is the capacitor of the ICD. And then below, you can see the battery and the other circuits of this device. So this is an ICD. But when you see the device, how can you recognize what device it is? Obviously from the appearance of the device itself, but also to what sort of leads are connected to the device. So you can see three leads which are connected to the device. One is in the right atrium, one is in the right ventricle, the lowermost, and one which is going to the lateral border of the heart is through the coronary sinus and going into the branches of the coronary sinus. So it's a CRT ICD. Why do I say an ICD? Because the device shows as a capacitor, it's a bigger device. And then the lead which is going into the right ventricle has two coils. So these are two shocking coils, and hence it is an ICD lead. So this is a CRT ICD device. This is a zoom up of the LV lead, so to say, the coronary sinus lead. And you can see there are multiple poles. So there are 4 poles in this lead. So it's a quadrupolar lead. And the more the poles, the more the luxury that we have in programming this device and stimulating different parts of the lateral left ventricle. A recent advancement is in this His bundle pacing, or better called a conduction system pacing. So why we know the detrimental effects of long-term RV pacing is that the patient can develop cardiomyopathy, which can be related to long-term detrimental effects of RV pacing. So to minimize that, if you manage to put a lead into the His bundle or close to that area, we can engage the conduction system by stimulating the conduction system and get more physiological pacing. So the paced QRS will be more narrow. Both the right and left ventricles will get depolarized through the His-Purkinje system, and you can get a narrow QRS. So this is a very exciting option nowadays. This is a diagram which the inset shows that the His bundle, you try and manage to put a lead, which is a screw-in lead, on close to the region of the His bundle, or actually at the His bundle, and try and stimulate the His bundle. So this will again be a dual chamber pacemaker with the lead in the right atrium and one lead in the conduction system or the His bundle. So it will almost look like an atrial lead everybody's aware of, but the right ventricle lead is not in the septum, it's not in the right ventricle apex. It looks in a bit odd position, as if it is another dislodged lead which is somewhere else, but this is where it is located. So it's the His bundle, but this is how it looks like. And now just get rid of the leads, just put a pacemaker which does not have a lead. This is the implantable pacemaker, which is a leadless pacemaker, which does not have a lead, and it is done through a transcatheter approach. So we go through the transvenous approach to the femoral vein. It's a big sheath, which is a 25 French sheath, and it houses the device. The small leadless pacemaker is almost slightly bigger than a size of a capsule. So it's a very small device, and through the transcatheter we go across the tricuspid valve, and this sort of pacemaker has a tined, if you can see at the end, which lodges it into the trabeculum of the right ventricle, and then this is how you deliver the device. This does not have a lead. And this is how it looks like on the X-ray, that you have a device in the right ventricle apex without any leads. So this is a leadless pacemaker. The pacemakers are checked by a programmer, because the pacemakers are programmable devices. They have their own features, mainly sensing and pacing. So that's the main function. But you can program the device. You can get diagnostic information from the device. You can program the different threshold sensing and pacing from the device, and get a lot of information of the patient's rhythms also. So the device also has a lot of diagnostics and very sophisticated algorithms. So you all do this by interrogating the pacemaker, putting the small programmer wand on top of the pacemaker, so it gets all the information, and you can then it gets displayed onto the small computer. You want to make any changes, you make those changes from the computer, and it gets transferred to the pacemaker, vice versa. Now, I like to go through a few electrical concepts and terms, because when you're going to read the chapter of pacemakers, this will kind of, it's important to get these things cleared out. So lead polarity, it's pretty simple. You have a pacemaker. This is a unipolar pacemaker system. So the lead is a unipolar lead, which means it has just got one pole with which it can stimulate the heart. And the pole is only at the tip. By convention, the pole which is at the tip gets contact with the heart is the cathode or the negative electrode. The anode is the pacemaker can itself. So this is a big circuit between the cathode at the tip and the anode at the pacemaker itself. So it's a big circuit. These were older pacemakers, and now the technology has moved towards bipolar pacing systems. But some old pacemakers you may come across have this unipolar pacing system. One disadvantage of this pacemaker would be that because of a big circuit, it can be prone to oversensing. One advantage, however, is that they have a very big pacemaker spike. And if you see a pacemaker ECG with a very big spike followed by a depolarized QRS, paced QRS, we can absolutely know it's most likely a unipolar pacemaker. The other pacemaker technology is the bipolar pacing system. So you have got two electrodes at the one at the tip, which is again the cathode, the negative electrode, but there's one electrode which is a bit proximal to it, which is the anode. So here the pacemaker is not part of the circuit, and the lead has two electrodes, distal one, the cathode, and a proximal one, which is also called the ring electrode. So the circuit is between these two. So it's a smaller circuit. The pacing is delivered between these two. The sensing is between these two. So so you've got a lot of advantages. However, the pacing spike is very small, and on an ECG, you may be in some leads, it may find very difficult to really spot out a pacing spike. So it's a very small pacing spike on the ECG. Go through some other electrical terms like the pacing threshold. So the pacing threshold is a minimum electrical stimulus needed to consistently capture the heart outside its own refractory period. It means that it's the amount of current that you're delivering through the pacemaker which consistently captures the heart. It is measured in volts, and there's a slight difference between the threshold or the capture threshold versus the amplitude. So the capture threshold is that if you start pacing the heart and you do a test in which you note how much, what is the least amount of current which consistently captures the heart. For instance, you start from 5, 4, 3, 2, and 1. And at say 1, there is a loss of capture. So there's a pacing spike, but does not capture the heart. So that is your threshold. That is your capture threshold. But in a device, in a permanent pacemaker, what amount of current you would like to have consistent depolarization will be higher than this, because you would like not the patient has sometimes some variability in the threshold and he loses capture. So you would like a consistent capture. In that case, the set the set voltage that you program in the device is called the amplitude. So if there is a loss of capture at 1, say 2 is your capture threshold where there's consistent capture, you would like to program the amplitude twice of that. So the amplitude of 4 will ensure that there is no fluctuation and the patient is safe and he will have consistent capture. So amplitude is the device, the setting that you program in the device. Not only is that you have to deliver current, but it's also important how much time do you apply that current to consistently capture the heart. So here the current is fixed at 5 volts. If you applied it for 0.5 milliseconds, as opposed to 0.25, which is a very short duration, as opposed to 1 millisecond, which is a very long duration. So if you go on the right side and do it for 1 millisecond, which is a longer time duration and a high voltage, you will definitely ensure capture all the time and the patient will be absolutely safe. But the problem will be that the battery longevity will become significantly compromised over the long run, because you're giving an unnecessarily high current. So you would like to go for optimal settings, and usually an amplitude which is almost twice your capture threshold is an economical setting, is a safe setting, and usually the pulse width program, that the duration is 0.4 milliseconds. So this is a very economical setting which will ensure good battery longevity in the long run. Then what about sensing? So the device also needs to sense the heart, and usually the pacemakers are programmed in the demand mode, and the electrode which is in contact with the endocardium, usually the patients have some sort of rhythm going on. At times they have some escape rhythm, they may have some PVCs. So these can get detected, and when the device sees those depolarizations, it inhibits itself and it inhibits its pacing. So that's the way this is called sensing, and it is expressed in millivolts. This is a small cartoon which shows that the lead is in the ventricle, myocardium, endocardium, and there is a wavefront of depolarization, the small blue arrows which are coming towards the lead electrode, and then they go away and depolarize the further parts of the heart. So on the bottom, you can see a voltage time relationship, and you can see this signal which has a wavefront which is coming, because it's coming towards it, so it records a positive small deflection, and then it goes away, it records a negative deflection. So this whole uh, signal complex is your sensing. So this is a sensed signal, maybe 4 or 5 millivolts or 10 millivolts. So this is your sense signal. This is called sensing. And if it is in the atrium, it is supposed to record P waves or atrial depolarization. What is the difference between sensing and sensitivity? Again, sensing is the ability to see the native depolarizations of the heart, and sensitivity is the value that you program in the device to enable demand pacing or inhibited pacing. So in that case, if the patient's supposing the R wave is 10 millivolts, you would like to program the device, the sensitivity in the device, which would be half of that value, so that if there is any fluctuation in the R wave over time, that sensitivity value will ensure that the pacemaker always sees that sensed signal. The greater the number of sensitivity, it goes the other way. So if you make the device less sensitive, that is a sensitivity number, if you increase, you will make the device less sensitive, or in other words, you will increase the number of sensitivity. and vice versa. If you want to reduce decrease the number, you make the device more sensitive. So consider sensitivity as a wall. So you can see a person standing behind the wall, and there is this 5 millivolts amplitude, which is you can barely see the person. But if you program it to 2, you may be able to see almost half of that person. And most of the time, if his height is increasing or decreasing with time, you may be able to consistently see him throughout with this setting. But why don't you program the sensitivity very, very less, actually very, very high, or the number very, very low? On the right side, it's like 1 millivolt. Then you will also see unwanted things that you don't want to see. Here, the devil is the small dog that's accompanied with that person. You don't want to see that. So in the pacemaker world, it will be similar to the T wave. You don't want to sense the T wave. If you increase the sensitivity so much or reduce the number so much, then you may be able to see T wave, and the pacemaker may start its timing from the T wave, which you don't want. So an appropriate setting will be almost half of what the pacemaker sees as sense signal. Again, this is just to clarify between sensing and sensitivity. So remember, imagine the tree height of 10 millivolts. If you place a fence on top of it, in front of it, which is 2.5 millivolts, you may be able to see a lot of tree, and you may be able to consistently see it. But if you make the fence 10 millivolts, so the sensitivity is now 10 millivolts, you make it less sensitive, you may not be able to see the tree at all, even though it exists. So you want to make it the sensitivity value at least half of what the sense signal is. Then talking about pacing intervals, we think of heartbeats as beats per minute, the cardiac cycle in terms of beats per minute. The pacemaker works in terms of milliseconds. So this is a more accurate way of measuring intervals. And the beats per minute and millisecond is very easily convertible by the rule of 60,000. So you write 60,000 as the numerator, and the denominator, if you put beats per minute, you get the answer in millisecond. And if you know the milliseconds, so you put it down 60,000 and you get the answer in beats per minute. So this is the rule of 60,000. Very important, you can now see a pacemaker ECG just in a very basic form, and this is a ventricular pacemaker with a VVI pacemaker. You see pacing spikes, big spikes, most likely unipolar spike with ventricular capture. And the third beat is a native sinus beat. When the pacemaker sees it, it holds its pacing. So it does not pace the way it was pacing at 60 beats per minute. So on the top is shown the way the pacemaker resets. So when it does a pacing spike, its counters increase to 1000 millisecond. For people not very sure what is 1000 milliseconds, so 1000 milliseconds is equal to 60 beats per minute. The pacemaker usually functions at a base rate of 60 beats per minute. It's programmable, but usually by default it's 60 beats per minute. So when there's a pacing spike delivered, there is 1000 millisecond counter which is full. Then it starts to decrease or decrement it till 0. If there is no event between one pacing spike and the other pacing spike, it delivers a pacing spike, and again it fills up its counter to 1000 millisecond and starts decrementing. But here, somewhere between 400 500, there was an intrinsic beat. So this resets the pacemaker. The pacemaker resets to 1000 milliseconds. It fills up its counter again 1000 milliseconds, and then does the same thing again. And here there was no other event, so its timer went off, it became 0, so it delivered a pacing spike, and so on and so forth. So just to don't get flustered with this thing, because whenever you see a sense beat, either be a PVC or native beat which is coming along, the pacemaker will inhibit, and this is the way it will inhibit. So in order to see did the pacemaker sense this beat correctly, what you do is you take the beat after it, the pacing spike, and walk back. So in this case, it should be 5 boxes from that pacing spike back towards that native rhythm. So it means that it was at 60 beats per minute or 1000 millisecond, and this sinus complex QRS was absolutely correctly sensed by the pacemaker, and the pacemaker got inhibited. Then there's a term which is called impedance. Impedance means it is the resistance to the flow of current. So the battery delivers the current, the current goes to the lead and goes to stimulate the endocardium. What is the resistance in the whole circuit? So through the lead to the myocardial tissue. So this is called impedance. It is represented in ohms, and the normal value of lead impedance is between 300 and 1200 ohms. The value is important because if there are lead issues like a lead failure, like a lead fracture or a lead insulation failure, there can be alteration in the value, and a lead fracture will give you a very high value of more than 1200 ohms. On the other hand, a lead insulation failure can give you very less value of say 100, 90 or 80. That would suggest a lead insulation failure. So impedance is important for from that standpoint. Now, to the second part of our talk, we have the paced rhythms, and we are going to approach this pacemaker ECG rhythms. So just like you approach a standard ECG, in which case you have a methodical approach, so I would suggest the same approach for the paced rhythms. So the first thing that you have to do is identify a pacing spike. So if you see a pacing spike followed by some depolarization, it's a pacemaker ECG. So the first thing is that. And then you have to identify, is it a single chamber or dual chamber pacemaker? So if there is a synchrony of atrial and ventricular events all the time, it is a dual chamber pacemaker. And if you just see ventricle pacing, it is a single chamber ventricular pacemaker. If you just see pacing followed by atrial depolarization, it's most likely an AAI or single chamber atrial pacemaker. So the second, the third, then you have to see what is the mode the pacemaker is programmed. So it will be usually in inhibited mode. So it can be a VVI pacemaker, AAI pacemaker, DDD pacemaker, and usually the lower rate programmed is 60 beats per minute. Then you can comment on the underlying rhythm, because you may see some sinus rhythm going on. The patient may have an atrial fibrillation with a very slow rate or complete heart block, which required a pacemaker. So atrial fibrillation may be evident. So just like a simple ECG that you see, you can identify the rhythm, or it may be just a sinus arrest. You don't see any P waves, and you just see atrial pacing. So it is a sinus arrest. So you can comment on the underlying rhythm. Then verify the pacing function, and there are two components of it. One would be a loss of capture. So in that case, the pacemaker delivers a pacing spike in that appropriate chamber, for instance, a ventricle, but you don't see a depolarization. So this can be loss of capture. Much will be a failure of output, that the pacemaker and one or third, fourth complex, you don't see any pacing output. So that will be failure of output, very rare, and usually a sign of battery depletion or circuit problem. Then I identify sensing function, and sensing function, you have to comment on two things. Is it normal function? So it may be an appropriate demand pacing that the pacemaker appropriately inhibits. On the other hand, it can be oversensing. So the pacemaker is seeing signals which it is not supposed to see. And whenever the pacemaker sees extraneous or other signals, it gets inhibited. So when the pacemaker gets inhibited, so what will you see is that the pacing will go down very, very low. So the pacemaker rate falls down to from the base rate. Think of oversensing. The other thing will be undersensing, in which case the pacemaker is the intrinsic depolarization is there, but the pacemaker, for any reason, because of any alteration in the sensitivity, is not able to see the intrinsic depolarization. So it will not see it even if it is there. And when it does not see it, so what would happen is that the pacemaker will think that I have not seen any depolarization, so I will pace at my lower rate. So you will see a pacing after an intrinsic complex. So you will see pacing at unexpectedly faster intervals. So think of undersensing. In other words, if you see less pacing, think of oversensing. If you see more and frequent pacing despite intrinsic depolarizations, think of undersensing. And a few special features which may be of interest and may be asked in exams would be there are many features of the pacemaker, I can tell you, but for cardiology exam or for just as a general cardiologist, you should be aware of a few functions like the automatic mode switch usually happens when the patient has an atrial arrhythmia, a dual chamber device. It switches to from a DDD mode to a VVI mode. That is usually an automatic mode switch or mode switch, as they say. The other one is hysteresis. We'll go over it. Then upper rate behavior, pacemaker Wenckebach or pacemaker 2-to-1 block. And then finally, it may be pacemaker mediated tachycardia. The specific type of which is maybe an exam favorite, would be an endless loop tachycardia. So we have representative ECGs of all these, and we'll go over it. So just as a small to start interpreting ECGs, the dual chamber pacemaker has lead in the atrium and the ventricle. It may function in 4 different ways. So the patient has a dual chamber pacemaker, say for instance for complete heart block or which for sinus node disease, and the patient's rhythm intermittently comes up and the patient starts conducting 1-to-1 through the AV nodal conduction system, or the patient's sinus rate accelerates and gets better than the lower programmed pacing rate. So you will see a native, you'll see an ECG without any pacing spikes, but at a rate above 60 beats per minute. So a dual chamber pacemaker may have just a normal looking ECG. The patient still has a pacemaker, but it's not evident because you're not able to, it's in an inhibited form. It's working in the inhibited form, and you are not able to see any pacing. But that does not mean that the pacemaker is not working well. So this would be an A sense followed by ventricle sense. The other one would be in a patient who has a very slow sinus rate. So this patient, but an intact AV nodal conduction, in that case, there will be an atrial pacing at the base rate of 60 beats per minute. And when the atrium gets depolarized from atrial pacing, it conducts to the normal AV nodal conduction system and gives you the QRS. So in this case, the configuration will be atrial pace followed by ventricle sense. The third beat shows an atrial sensed event followed by a spike in the ventricle and the ventricle depolarization. In other words, it's an A sense V pace. This will be the configuration in a patient who has complete heart block. Sinus node is fine, sinus rate is okay. It's only the problem in the AV nodal conduction system. So it's A sense and V pace. And the fourth one is atrial pacing followed by ventricle pacing, called AV sequential pacing. Here, the sinus rate is slower than the lower programmed rate, so the atrium has to get paced. And the AV nodal conduction is also not great, and the ventricle also needs to be paced. So this will be, so these are the 4 ways in which a dual chamber pacemaker can function. Now, so let's go over some cases. So I'm displaying you this ECG, and believe me, all ECGs today will be pacemaker ECGs. So no catches here. So if you carefully look, it's very difficult to see pacing spike. The QRS looks absolutely normal. So you don't see any pacing spike. Now, the first thing to identify is what sort of pacemaker is this? Do you identify pacing spike? Yes, lead 2 gives you some spikes, but they are before the QRS. And in some forms, you can see that the pacing spike is followed by an atrial depolarization. So it is most likely an AAI pacemaker. And if you time the atrial pacing spike to the next atrial pacing spike, there are 5 small squares. So in that case, it would mean that it is almost 60 beats per minute. So the way you will interpret this ECG is that it's a pacemaker ECG. It's an AAI pacemaker mode programmed at a lower rate of 60 beats per minute with appropriate atrial pacing and capture. Can we comment on atrial sensing? The answer is no, because we don't see any intrinsic atrial activity to suggest that the pacemaker's atrial lead saw that and withheld its pacing. So we can't comment
but most likely it will be normal. But here in this specific instance, in this ECG, particular ECG, we cannot comment. So the way to just the way to interpret on an exam, and a lot of PGs say that how would you write it in the exam would be, this is a pacemaker ECG showing an AAI pacemaker programmed at a lower rate of 60 beats per minute with appropriate atrial pacing and capture. Both are important. So if you pace the atrium, it should also capture. So you can see a depolarization. The pacing spikes sometimes because of the filter settings, like you can see the low pass filter of 40 hertz here. Sometimes you have to increase the filter settings to enable a bigger spike. So the way usually the ECGs are recorded in routine practice, so the spike can look, in a bipolar spike can look very small. Sometimes the atrial depolarization may not be visible in different leads, and you may actually say, no, it is not capturing in the atrium. I see a spike, but it's not capturing in the atrium. But then you have to look at multiple leads. Again, it's all because of the filter and amplification function of the ECG machines. That creates a lot of confusion. But if you look at lead 3, you see the pacing spike followed by capture. If you look at lead V2, it definitely shows a pacing spike followed by atrial capture. So that is where the atrial capture is, and it is normal. Moving on to this one, this is a rhythm strip. It shows, you see ECGs complexes, and on the left side of the paper is a slower speed, and then the speed picks up. The first 3 complexes have an atrial pacing, followed by atrial capture, clear. There is AV nodal intact conduction, so the QRS comes through the AV node. Uh, Hello, can you please just tell me, can you hear me?
Yes, sir, we can.
No issues?
No, it's perfectly fine.
Okay, perfect, great. So you have atrial pacing followed by atrial capture on the first 3 complexes, and then you can see that the atrial rate, which is a sinus rate, which picks up, and it's faster, almost close to 90 or 100. So the sinus tachycardia comes in, and the pacemaker holds its pacing, and it is perfectly sensing well. And this is a normal function. So it's an AI pacemaker with appropriate atrial pacing and capture, and appropriate atrial sensing, because when the pacemaker sees impulses coming, atrial events coming, and it holds its pacing. So this is appropriate AI or atrial demand pacing. Moving on to this ECG. So on the bottom, you have a rhythm strip, and on the top, you have 12 lead ECG. So the rhythm is atrial fibrillation. You don't see any visible P waves, that's for sure. Okay. Now, what sort of pacemaker is this? Atrial fibrillation, everybody's guess, should be a VVI pacemaker. Okay. So we see pacing spikes in lead 2 and 3, AVF also, and these spikes are followed by ventricular depolarization. So this is a ventricular pacemaker. Fair enough. Uh, but on the rhythm strip, you don't see any pacing spike. Why is that so? So the pacemaker is programmed at a slightly lower rate of 50 beats per minute. You can see the 6 moles, 2, 3, 4, 5, 6. Yeah. So it's 50 beats per minute. But because it's atrial fibrillation with its conduction, and when the rate avenodal conduction improves above 50, the pacemaker gets inhibited and it does not give its pacing spike. So this is the appropriate response to the pacemaker. So this is underlying rhythm atrial fibrillation, ventricular pacemaker or VVI pacemaker, programmed at a lower rate of 50 beats per minute, appropriate ventricular pacing and capture, and appropriate ventricular sensing. So it's a normally functioning VVI pacemaker. Now, so this is an ECG which shows pacing spikes, and there are 2 pacing spikes. So one spike followed by another spike. One thing is clear, that the second pacing spike is capturing the ventricle, because you see a white QRS paced ventricle paced complex. So it is that way. But how, as I told you before, that how to recognize a single from a dual chamber pacemaker is that a atrial and ventricle events, the 4 forms that I told you before, the A sense, V pace, A pace, V pace, A pace, V sense, A pace, A sense B pace. So the four forms, they are tied together. Here you see an atrial pacing followed by ventricle pacing. So it's a dual chamber pacemaker. And again, it will be very difficult for you to, or me to convince you that the atrial lead is capturing the atrium, but possibly lead 3 is giving an atrial pacing spike followed by atrial depot capture. So it's appropriate dual chamber pacemaker with appropriate atrial pacing and capture and appropriate atrial ventricular pacing and capture. The atrial and ventricular sensing cannot be commented on this particular ECG because the patient's sinus rate is slower than the programmed rate. The patient's avian conduction is not great. So we cannot comment on atrial and ventricle sensing, which does not mean that it is abnormal, but only we cannot comment. So it looks like appropriate AV sequential pacing. Moving on to this rhythm strip, it shows four complexes with 2 spikes. So it's atrial pace and ventricle pace. And here you can see a good atrial depolarization. But you look at the 4th complex, you see an atrial pacing spike, but you don't see a P wave. So there is loss of atrial capture and ventricle pacing is okay. That's fine. But then the other beat shows apparently a P wave. The last one shows a P wave followed by ventricular capture. So how to interpret? So it's a dual chamber pacemaker, that is for sure, because atrial ventricular events together cannot be a VVI, cannot be an AI. Dual chamber pacemaker. So there is intermittent loss of atrial capture. So that is the malfunction of this. This is not normal because the 3 complexes are captured well, and the 4th one is there is loss. So maybe the threshold or the amplitude programmed in the device is so borderline between the threshold and the amplitude that sometimes the safety margin is not there and the pacemaker is not able to capture in the atrium. So this is a malfunction, which is an intermittent loss of atrial capture. The loss of capture may be constant throughout. It will be a loss of capture, and here in this case 3 capture and the 4 does not capture, so it is intermittent. What about atrial sensing? Sure, the last beat is an atrial sensed event, and hence it was tracked followed by a ventricle pacing. So it means that the atrial sensing is appropriate. So it's a DDD pacemaker with intermittent loss of atrial capture. That's the malfunction and appropriate atrial sensing. So that would be the conclusion. Moving on to this one, again, if you look on the right of the strip, you see 2 pacing spikes. So it has to be a dual chamber pacemaker. And not only that, on the first 5 complexes, you see P waves, which look like sinus P wave, followed by ventricular capture. So it is timed, the atrial and ventricle events are synced together, they're timed together. So it has to be a dual chamber pacemaker in that case also. So it's a dual chamber pacemaker. Atrial sensing is appropriate because every sense beat is followed by ventricle pacing. So it is tracked well. So this is appropriate atrial or say P synchronous pacing. And the second last and the third last beat are atrial paced, but they are not captured. So this is loss of atrial capture, and this is the malfunction of this device. So atrial sensing is appropriate, ventricle pacing is appropriate, atrial pacing has malfunction, which is a loss of capture. Here it is not intermittent because 2 times it required pacing in the atrium and both times it failed. So this is a complete loss of atrial capture. And how would you treat this patient? Would be that you increase the you do a interrogation of the device, see what is the atrial capture, and then increase the atrial amplitude from that set value, because that value, whatever is programmed in the device, is insufficient for this patient to attain atrial depolarization. Now this is an interesting ECG which shows some native beats, and intersperse you see some ventricular pacing. So in quick look, it looks a bit confusing, but let's be brave and see what sort of pacemaker is this. So you have a pacing spike followed by ventricular depolarization. So it has, and there is only one pacing spike throughout the strip. So it has to be a ventricular pacemaker. So the chamber pace gives you a clue where the lead is located. So it's a VV ventricular pacemaker. I would not say VVI in this at this moment. Now, how do you make sense of the native complexes? And you can see the pacing spike actually walking through the whole strip from the left to the right. Now let's go beat to beat. So the first spike, the second spike, it's 60 beats per minute. Fair enough. The second to the third one, you saw a native complex and a T wave or an ST segment, and you see a pacing spike, and it does not capture. So because it was the heart was in the refractory period, this third pacing spike was not supposed to capture the heart because the heart is already repolarizing. So it's not out of its refractory period, hence it is not supposed to capture. So this is called a functional loss of capture. Then another sinus beat came along. The pacemaker was not very interested. And the fourth complex is a pacemaker spike followed by ventricular depolarization, and then the sequence repeats again, function loss of capture, pacing complex captures. Then this pacing spike is on top of a QRS, so it is not supposed to capture in any way. So is pacing function appropriate? The answer is yes, because where the heart is out of its refractory period, the pacemaker paces and captures, so that is fine, and there's no problem with ventricular capture. But the unusual thing is that the pacing spikes are walking through, even though a lot of sinus complexes are coming in between, the pacemaker is not respecting them, not sensing them. So in this case, this is a classical example of undersensing. The pacemaker lead is, even though it is there, but it is not aware. This is a very common thing that you will see with a temporary pacemaker, and in our hospital they record a 30 beats per minute temporary pacemaker ECG in the morning, and this is a asynchronous pacing, and this is exactly what happens. Sometimes the patient has his own rhythm and the pacing spike are walking through it. So this is undersensing. Or in other words, if you see a sandwiched intrinsic complex between two pacing spike, think of undersensing. Or frequent pacing, even though intrinsic complexes, think of undersensing. So this is an example of asynchronous VOO pacing with appropriate ventricle capture. Now this one, what sort of pacemaker is this? So we see 4 pacing spike followed by ventricular depolarizations. And we don't see a timing of atrial and ventricle events. So it has to be a VVI pacemaker, ventricular pacemaker. We see 2 sinus beats with a prolonged PR interval and a very slow atrial rate. And the pacemaker is programmed at a lower rate of 60 beats per minute. But between the first intrinsic or the third complex, so to say, and the fourth complex, the time interval is much slower than the pacing rate. So that means that the pacemaker is probably getting inhibited again and again by something, so that it is not causing a pacing spike to occur at 60 beats per minute. So this is an example of oversensing, that you see less pacing spikes. And below is the marker channel, which is a small strip that we record from the device when we are interrogating the patient in the pacemaker clinic. And that is something which is really telling the way the pacemaker is looking and functioning in this particular patient. So you see the first two, it is annotated as VP, stands for ventricular pace, so, rightly so, and the pacemaker captures there. And then you see a VSense, VS. And imagine where is the VS coming? It's coming in the PR segment. The lead is in the ventricle. It has got nothing to do in the PR segment and sees anything extraneous. Then it sees something in the ST segment, which is not supposed to do, or maybe in the after the T wave, and then before the P wave and after the PR segment, maybe in the ST segment. So the VS tells you that there's a lot of ventricular oversensing. Okay. On the surface ECG, you can just catch it by slowing of the pacing rate. Okay, from your baseline rate of say 60 beats per minute. But the marker channel, the pacement interrogation will clinch the diagnosis. So this is oversensing. Most likely this patient lead is not functioning well. Maybe it's an insulation break or a fracture on the lead, which is causing problems and oversensing. And the second last pacing spike will be probably timed to the last VS. So this is this was the last sense appropriate beat, and then the pacemaker started working again. Now this is a very interesting ECG. And I can understand uh, the problems that you may think, but let's keep it simple. So what is being displayed is 12 lead ECG. The bottom shows you a rhythm strip. First thing first, is it a pacemaker ECG? Yes, we see a pacing spike followed by capture. And now your eyes are so tuned up that I presume that everybody can appreciate a ventricle spike, even though it is very, very small. Okay, so it's a ventricular pacemaker. Do you see timing of ventricle and atrial events together whenever there's a pacing spike? No. So it is not a dual chamber. It is a single chamber ventricular pacemaker. Fair enough. What rate is it pacing? You see the first or the in the second or the third complex which is paced in the rhythm strip down below, and it's almost 2, 3, 4, 5, 6. So it's like 60 beats per minute. So which is fair enough. That is fine. Now what's happening in the first complex is a sinus beat, and then you see a very, very big pause, which is much lower than the pacemaker programmed rate. So then when you see less pacing, think of oversensing. So this is ventricular oversensing. How do you know what the pacemaker has sensed? You walk back from the pacing spike that you see, and you see that 60 will line up somewhere after the T wave of the preceding native beat. So maybe there's some sort of oversensing of the T wave or something else in the ST segment. The lead is not is working in a very fishy manner. So there's some problem and there's oversensing. The two pacing the spike followed by capture, that is fine. Then you see another native complex. Fair enough. The pacemaker should get inhibited, but you see a pacing spike and a capture immediately after the native complex. And this is unexpected. So that means that this pacing or this native depolarization was not sensed by the pacemaker. It sensed something else, and it is oblivious of this pacing spike or native complex. So it means that there is some sort of an undersensing. So there's an oversensing, there is an undersensing in the same patient, most likely a lead issue, which is causing a lot of problems. So this is a VVI pacemaker with ventricular oversensing, intermittent ventricular oversensing, and ventricular undersensing. So these are the malfunctions in this pacemaker. Now, this strip, this is not a true ECG, it's an artist drawing. So, but just to get the concepts through, you see is it a single or dual chamber pacemaker? Tough to say, because on the right of the strip or the you can see a lot of P waves, so looking like a flutter sort of an appearance. And the first two complexes apparently look like sinus P waves. The atrial rate is definitely slower and looks normal. So it's A sense followed by V pace, the first two complexes. So it's a dual chamber pacemaker. And then you see pacing, ventricular pacing at erratic, irregular fast rates. And then it slows down and becomes the ventricular rate, pacing rate becomes regular. So what is this? This is a dual chamber pacemaker. There is an onset of an atrial arrhythmia, likely an atrial flutter, and the pacemaker has automatically changed its mode from a DDD to a VVI pacemaker mode. So it has shut off its atrial channel after a while when it notices. Initially, it tries to track the atrial flutter at a faster rate, but it few in the four, 5 beats, it realizes, no, this activity is not consistent with sinus rate. It is super fast, and I don't really need to pace and track it that fast in the ventricle, and it inhibits itself, from the atrial channel. It shuts it off and changes its mode from triple D to VVI. So this is mode switch in a patient with a atrial flutter, and a patient has a dual chamber pacemaker. Now, this ECG shows you good sinus activity. Where is the pacemaker? Oh, the pacemaker is on the right side of the page. You see pacing spikes uh, followed by ventricle capture. So what sort of pacemaker is this? On the right side, you may say it may be dual chamber. It may well be a dual chamber, because what I've told you so far is if you see a timing of atrial and ventricle events together, it has to be a dual chamber pacemaker. But here, the pacing spike is not associated with any atrial activity preceding. So it is a VVI pacemaker. It is a ventricular pacemaker. Fair enough. What rate is it programmed? It's exactly programmed at 60 beats per minute, pacing well on the right of the strip. So all good here. On the left of the strip, you see a sinus activity, sinus rhythm going on at a slightly faster rate of 70 beats per minute. So this is above the pacemaker's lower programmed rate. So it means that the pacemaker was inhibited and it withheld its pacing because the patient's intrinsic rhythm was faster. And you see a pause and then followed by ventricular pacing only. Uh, Coincidentally, the pause is such that you walk from the left of the last pace beat, or I mean the first pace beat, and it times out to be six, 1, 2, 3, 4, 5, 6 small squares. So this is 50 beats per minute. So the pacemaker sends the last beat at 50, and then there's pacing going on at 60 beats per minute. So this is an example. It can be oversensing, ventricular oversensing. The pacemaker, got inhibited for some reason and started pacing late, or it can be an example of hysteresis. And what hysteresis actually is in patients who have sinus node dysfunction, you have a you don't want to pace. You put a lead in the ventricle, which you should not be, because the disease is in the atrium. So you put an atrial lead. But if you put a ventricular lead and the patient has his own rhythm going on at times, you would like encourage the patient's rhythm. The pacemaker would like to encourage the patient's rhythm, not at a rate of 60, but at a slightly lower programmed rate or a hysteresis rate of 50. So if the patient's rhythm goes on, the pacemaker would not, after there's a pause, it would not pace at 60. It will go to a lower hysteresis rate and wait till 50. Maybe the patient's own sinus beat comes in. And if it does not, then it starts pacing at 60, 60, 60, till the time there is an intrinsic beat which kind of interrupts the cycle, and the pacemaker again starts pacing at uh, 50 and then at 60. So this is called hysteresis. Now this ECG shows you some group beating. Is it a single dual chamber? It is a dual chamber pacemaker. You see the second group. There is starting with a P wave, sense P wave followed by ventricle depolarization, and you see a gradual prolongation of the PR, A sense V pace interval. The P wave is actually going on top of the T wave, on top of the T wave, on top of the T wave, till the time it goes on almost the uh, top of the T wave. So the pacemaker has its own refractory period. So it falls in the post-ventricle atrial refractory period, or so-called PVARP, PVARP, and that is where the atrial channel does not see the P wave, and hence it does not track in the ventricle, and you see no pacing spike either. And then the pacemaker starts pacing again and doing the same things. Imagine, just see that the patient's sinus rate is very fast here. So the pacemaker is programmed at a lower rate and also an upper rate in a dual chamber pacemaker, usually typically triple D 60 by 120 or 130. So at above 130 beats per minute, the pacemaker has a safety feature that it would not track very, very fast rates, 130, 140, and it does a Wenke-back sort of a thing. So this is called a pacemaker Wenke-back. It's a normal pacemaker function as seen in fast heart rates. Especially if you put a patient with a dual chamber pacemaker on a treadmill, this is what's going to happen. This is a normal function. And this is showing on the left of the tracing, you can see a sense V pace timing interval increasing the PR interval, so to say. And then you see a P wave on top of the T wave, which is not tracked. Hence, you don't see ventricle pacing. And then the next P wave is tracked and paced in the ventricle. Then another P wave, the patient is really fast. The sinus rate is really getting very, very, very fast. So initially it Wenke backs. And if the patient is on a treadmill and he goes even faster in sinus rate, then he develops a 2-to-1 block with the pacemaker. So the pacemaker Wenke back and 2-to-1 block is is a normal function of the device. It's the way the device is programmed, and this is called an upper rate behavior of the pacemaker. And this is the marker channel showing you the intermittent 2-to-1 AV block with the pacemaker with sinus tachycardia. Just one quick trace. So this is dual chamber pacemaker, A pace, V pace, and then suddenly something happens and the pacing rate increases very, very, very fast suddenly. So this is not an upper rate behavior. This is a classical example of an endless tube tachycardia, which is a pacemaker mediated tachycardia. And what happens is that the pacemaker, the rate when it gets faster, there's an atrial loss of capture. The ventricle paces on its time. but then you can see a retrograde P wave in the T wave, and that gets tracked to the next pacing at a faster rate. The ventricle pace again conducts retrogradely, and the cycle starts. So this is an endless loop tachycardia or a pacemaker mediated tachycardia. So this is what it is. But usually there's a trigger to it, and so that's it. Now just a couple of slides left. So this is a pacemaker. The gain settings are a bit slow, so you're seeing a very small complex. Sorry for that. But what sort of pacemaker is this? It looks like a dual chamber pacemaker because certainly you see pacing in the ventricle, and maybe best evident in lead V1 that you can see small P waves before the pacing spike. So it is A sense V pace. The QRS complex looks pretty narrow, much narrower than what I've shown you in the ventricle pacing. And not only that, but look at lead V1. It is initial deflection is positive. It gives you kind of a right bundle sort of morphology. And limb lead 1 is negative QRS complex. So this is an example of a CRT pacemaker in which there's a biventricular pacing. The initial depolarization is from the LV lead, so it gives you a right bundle sort of morphology. The remainder part of the QRS is with the right ventricle lead, so biventricular pacing. V1 would look negative, limb lead 1 would look negative, and it will be a dual chamber pacemaker, so you will see A sense V pace through. So this is a CRT or a biventricular pacemaker. And just final slide is this. So you see two pacing spikes, atrial pace and ventricle pace. Believe me, the atrial pace is captured, and but don't believe me that the ventricle pacing is capturing the ventricle. Does it look like pacing in the ventricle? No, because so far what we've seen is the pacemaker spike would look left bundle branch block in the lead 1, very wide QRS 2-3 wave would be negative with ventricle pacing. This is an example of his bundle pacing. So you're pacing the conduction system. I showed you that figure in which the ventricle pacing is you're pacing the conduction system in the His bundle, close to the His bundle. You are going through the His Purkinje system, and it's resulting in a narrow QRS. So actually you get a QRS which is just intrinsic QRS. So this is really lovely for a His bundle pacing. So this is a dual chamber pacemaker, and this is a His bundle pacing, which gives you a narrow QRS. And I think that's my last slide. If there are any questions, I'll be more than happy to answer.
Thank you so much, Dr. Faisal. That was an amazing session. I hope everyone got benefit from it. We had almost 100 plus participants. You can write down your questions in the chat box or in the question and answers section. We have a question from Dr. Shakila Naz. She says, limitation of His pacing and which patients cannot get it.
Okay, as of yet, the His pacemaker patients you're going to select would be patients who, the ideal patients would be somebody who, any patient who needs a pacemaker should get a dual chamber, should get a His bundle pacing. That is fine. But because we don't have a lot of randomized trials, it is a recent technology. So the way we are doing here is that patients who have failed CRT implants have a left bundle branch block morphology, and we would like to pace. It's actually very interesting the way the His bundle pace, because if you have a left bundle branch block, how can you pace the His bundle and get rid of the left bundle? Doesn't make sense at all. So there are the concepts of longitudinal dissociation of the AV node and a source or sink mismatch and a few other hypotheses. So there is just load conduction through the left bundle, and if you pace proximally at the His bundle, there are some dedicated fibers in the AV node, after the AV node, close to the His bundle region, which are dedicated and destined to become the left bundle. The block is usually there. So if you pace slightly distal to it,
you can actually overcome the left bundle. So the answer to your question will be all pace in center, because this is a technology which very few people are doing. A lot of randomized trials are lacking. It is not at the moment comparable to CRT pacing, uh, because it would make good sense that CRT, even if you have left bundle and do a CRT, you can really not narrow the QRS to absolutely normal values. It will still be a wider QRS. So with his bundle pacing, you can get a really narrow QRS. So it looks exciting, but the best patients practically will be those who have failed CRT implants because the anatomy was not good. We're not able to put a CRT lead. And if we get rid of that left bundle and recruit the left bundle, get a narrow QRS, they will be the best patients. But for practical purposes, any patient who's got a conduction system disease, sinus node, AV nodal disease, can get his bundle pacing. There may be few patients who have distal left bundle branch block, and they may not be amenable with his bundle pacing. So you have to put a lead in the RV apex.
All right, thank you, Dr. Faisal. There's another question from an anonymous attendee. The question is that does the single chamber pacemaker only pace at a fixed rate only, or it can pace as per demand like patient exerts?
Okay, so if you're talking about a ventricular pacemaker, which is a VVI, so all pacemakers by convention would be demand pacemakers. So if it is a VVI pacemaker as opposed to a VVIR pacemaker, so if a patient has complete heart block and his escape rate is less than 30, the pacemaker will be pacing at a base rate of 60. But if you have a rate responsive sensor in the pacemaker incorporated, the patient's pacemaker, the sensor will usually the simplest sensor that's available is an accelerometer. So it senses the patient's motion. The pacemaker can move when the patient moves his upper torso, and it senses motion and accelerates the rate from a base rate of 60, and maybe that's programmable. You may go up to 120, 130. So at rest, when the sensor is not activated, the patient will be pacing at 60. But if it is driven by a rate responsive sensor, it can increase its pacing according to the sensor activation. So the rate may be variable. It may also depend upon if you record an ECG in a patient who has a VVIR pacemaker, and he's walking around and just coming and lying down on the bed, you record an ECG immediately. So his program rate may be 60, but his sensor would be activated because it takes a while that the sensor comes back to the base rate. So his rate may be at 80, and you may be confused that we programmed at 60, why is it at 80? So it really depends upon the sensor which is incorporated in the device.
All right, thank you so much, Dr. Faisal. There's another question from Dr. Ahmed Mohammed. He says in triple D pacing, the third D has T and I. How can we pick up the T part of the pacemaker function on ECG?
Okay, so the T and I, this triple D, the third word is the most confusing. Okay, so triggering or tracking means that it senses a native event in the atrium, and when it senses it, it tracks. Tracks means that it sees it in the atrium and triggers a pacing in the ventricle. So that is called triggering or tracking. So when the patient has complete heart block and you put a dual chamber pacemaker, program it triple D, so it senses atrial activity, and because there is no AV conduction, it generates an sensed AV interval and paces in the ventricle. So it is actually keeping track of the atrial activity, and whatever the atrial rate is, it will pace the ventricle accordingly. So this is called triggering. Inhibition usually is reserved for when a patient has his own conduction. So A sense, and supposing intermittent heart block or for some reason the ventricle got the AV node started conducting, and there is an A sense and ventricle sense going on. So the pacemaker also gets inhibited. So it's D because it can get triggered, it can get inhibited, it may do nothing, or it may so because it's dual chamber function, inhibition, sensing, inhibition, and triggering, so hence the D.
All right. Thank you, Dr. Faisal. Dr. Faisal, can we take a couple of more questions, if you allow?
Sure. Sure, no
Okay.
problems.
Okay. There's another question from Dr. Ismatullah. He says how to differentiate single chamber pacemaker from an ICD on a chest X-ray.
Okay, so you're not talking about ECGs. I'm glad that you don't ask this, because on an ECG you can't tell. An ICD usually is programmed at a rate of 40. So if a single chamber ICD is VVF 40 by default. Usually in an ICD you have a backup pacing function, and you don't unless you need a pacing function, you can enable a higher rate. But usually on an ICD patient, ECG will just look like a pacemaker ECG. I showed you the X-ray of a CRT pacemaker, CRT with ICD device. The device will be bigger as compared to a pacemaker. The pacemaker device I showed you is a smaller device with one, half part of it is the battery, and the other part is a bit shows a circuit, as if you've seen a circuit of a computer main board, or on an X-ray. So it shows you a small circuit. So that's a pacemaker. Conversely, an ICD will be a bigger device. Then you will see a rectangular sort of radiolucent appearance. That is the capacitor, because the ICD has to deliver shock. It stores its charge in a capacitor, and that capacitor has a volume, and hence the ICDs are a bigger device because they have to have this capacitor in them. The capacitor gives you that very nice rectangular radiolucent shadow, and the other part will be, you can see a small battery visible also. Most importantly, when you see a big device looking like an ICD, and you see the lead, so it's very important to see what lead is connected to the device. You see a lead which is connected to the device, and that lead has a shocking coil. It can never be a pacemaker. It has to be an ICD. So the ICD lead will get attached to an ICD. A pacemaker lead may or may not get attached to an ICD, but an ICD lead cannot be attached to a pacemaker, so to say. So you recognize the device from the appearance and also with the lead.
All right. Thank you, Dr. Faisal. There's another question that how to treat endostroop tachycardia in periphery like in MITI.
Okay, good question. A simple thing would be that it's just imagine this as AV node reentrant tachycardia. So the pacemaker is part of the circuit. Okay, so the slow pathway is the A sense to the V pace, and from ventricle pacing, it goes rapidly up into the atrium and gets sensed. So if you block the AV node in any way, you may actually get rid of the tachycardia. So if you give an IV verapamil or an IV adenosine, you may actually terminate. You do a carotid massage, you may theoretically terminate it because of increased vagal stimulation. So that is fairly possible. If you have a magnet available, you can put it on top of the device, because the tachycardia started because there is some sort of an oversensing, unusual sensing which is being tracked repetitively. So you inhibit sensing by putting a pacemaker on top of it, which makes the device asynchronous, and you may break the tachycardia. Or if you have a programmer available, you can refer them to our OPDs, and we will be happy to see that patient. And we can just do a small adjustment tweak, which is a increase in the post-ventricle atrial refractory period. So the P wave, which is coming on top of the T wave with retrograde conduction, we kind of increase the post-ventricle atrial refractory period, so that P wave is enclosed in that refractory period and it does not get tracked, and hence the tachycardia will terminate. I will tell you, it in modern pacemakers, you will probably not see it. I've not seen it in real life because the pacemakers are equipped with so much good algorithms that the pacemaker does its own tweaks and terminates it. Even if the patient has a ELT, the pacemaker is able to get rid of that.
All right. Thank you, Dr. Faisal. There's another question Can you please explain the difference between pacing threshold and capture threshold again?
Okay. So what you do is, supposing you have a TPM with you, you take the control box in front of you, the temporary pacemaker. You see a small thing which is called a knob, which shows you volts. That's your amplitude. That is the setting that you put in the device, and maybe it would be programmed at 4 or 5. So that means that the pacemaker is constantly delivering 5 volts, and you can see pacing in the ventricle with a temporary pacemaker. So this is the amplitude. This is the setting which is in the device. Maybe somebody before you've seen the patient has programmed this number. So this is a number in the device. This is called the amplitude. Okay, but you are interested to see where is what is the minimum amount of current in which the pacemaker loses capture. So what you do is that the patient is paced at 60. So you keep the rate at 60. You reduce the volt from 5 to 4. You see the patient is pacing, continues to pace. You reduce it to 3. Patient continues to pace. Reduce it to 2. Patient continues to pace. Reduce it to 1. Patient continues to pace. You reduce it to 0.5 and there is loss of capture. You see a pacing spike followed by a flat line. You immediately increase it back to 5. Now, the loss of capture is at 0.5. That is the minimum amount of current in which you are not able to depolarize the heart. So that is your loss of capture. One step above it is 1 volt, where you had consistent capture, but that was the least amount of current in which you had consistent capture. So this is 1 volt. So that is your threshold. The least amount of current which ensures consistent capture is threshold. Ideally, the setting of 5 is a bit luxurious for that patient. So what you would like to do is to minimize on the battery life, and an efficient setting which will be safe for the patient should be just double of your threshold. That should be your amplitude which you would like to set in the device. So in that case, it should be 2. Okay, but don't get it this way from because in temporary pacemakers, the patients, it's a temporary device. It's not the best lead. It may not be stable. So you would like to give some benefit and safety to the patient rather than worrying about battery life. So you may kind of do a miserly setting of an amplitude in a permanent device rather than in a temporary device. So the loss of capture is a low in which you don't see it. Threshold is the lowest current, and twice of that is a safety margin. And the device, the value that you set in the device after checking a threshold is the amplitude.
All right. Thank you, sir. We'll take just 1 or 2 more questions. Okay, we have another question from Dr. Ahmed. Okay, he asks, what is functional undersensing?
Okay, so you see, you have a pacemaker, which is it would be nice to show you an ECG of that. So what it means is that even though there is a sensed event, the patient, the pacemaker is not seeing it just because of a timing issue that the pacing spike came so early into it. Usually will happen with a dual chamber device. I could show you on an, it will be tough for me to explain it that way, but if I have an ECG in front of it, so that would be nice. Maybe I could bring one. So maybe you can discuss. It would be very tough for me to really explain you without the ECG in front of.
All right. Okay, sir. So we'll take another question. So someone asked, what are the indications of CRTP?
Okay. The CRT biventricular pacing, the 5 indications. The class 1 indications will be patients who have sinus rhythm, who have left bundle branch block, QRS more than 150 milliseconds, who have NYHA 2 to ambulatory 4 heart failure, who are on optimal medical therapy and have refractory symptoms. So CRTP and CRTD, the biventricular part of it is the heart failure part of it. So these 4 or 5 indications will hold true for either the CRTP or CRTD. So because basically you're putting it for heart failure patient who is not responding to medical therapy despite appropriate optimal GDMT, and he has a left bundle branch block which is wide. You would like to resynchronize the heart. So the indication for CRTP and CRTD will be the same from the heart failure standpoint.
Right. Okay, sir. Just one last question before we end the session. Um, there are so many. Let me pick the right one.
Dr. Samir, there's a last question. I think we have
Okay.
done the ones above that in the chat box.
Okay. So how to differentiate between endless loop tachycardia and sinus tachycardia in paced rhythm?
Okay. It will be the endless loop tachycardia will be a sudden onset tachycardia. So if you were to have a telemetry step of this patient, the patient would be in a sinus tachycardia, and it is at the upper tracking rate of say 130 beats per minute, triple D 130, which is upper tracking rate. So the sinus tachycardia and a ELT will apparently look similar if you see just one random strip in which the patient is in tachycardia. So it will be difficult. A sinus tachycardia will have a positive P in lead 2. An ELT patient would not have a positive lead P wave in lead 2. It will be retrograde P, so it will be a negative P, which will be tracked by the device, and the patient would be an endless loop tachycardia. Usually the onset of the tachycardia will tell you a sinus tachycardia or sinus rhythm tracking and sudden onset of tachycardia with some issue like a PVC or a PAC or an atrial loss of capture, what I showed you on that pacemaker strip. And then the tachycardia starts and it is fixed at the upper or maximum tracking rate. This is endless loop tachycardia. Uh, or it will be a sudden. So these are few things that you will differentiate with.
All right. Thank you so much, Dr. Faisal, for taking time out for this session and obviously all these questions as well. I hope everyone learned a lot today. This was specifically chosen to be given by you because I'm sure कि ये इतना अच्छा मैं और कोई समझा नहीं पाता. So thank you once again. I'm sure if anyone
Okay,
has any questions, they
I
can
also really
always
enjoyed.